Welcome to the new Antibiotic Stewardship Program Guidelines conference call. My name is Darrell, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Sarah Parkman. Sarah, you may begin.
Thanks, Darrell. On behalf of the Lake Superior Quality Innovation Network, I want to thank you all for joining us today to learn more about the new Antibiotic Stewardship Program Guidelines. It should be no surprise that there's been great interest in this webinar given the timeliness of the topic. A couple of housekeeping items before we get started. Slides for today's event were available for download on the login page and can also be found following the link in the chat box. Participant lines are currently muted by default. We will have time for questions at the end of the presentation, at which time you will receive instructions should you like to ask a question over the phone. We encourage you to use the chat box throughout to post your questions as they come to you as well. When you close out of today's webinar, you will automatically be routed to an event evaluation. We appreciate you taking time to provide us with your feedback. Upon completing the evaluation, you will have access to a certificate of participation for your records. Finally, today's webinar is being recorded. The recording will be made available on the Lake Superior QIN website and YouTube page sometime next week. Before I introduce today's speaker, we want to start off with a polling question to get a sense of where everyone is currently at with regards to an antibiotic stewardship program at your facilities. So the question is, does your facility have an antibiotic stewardship program in place? Your answer choices are no, we don't have an ASP in place. We have some pieces of an ASP in place, but there isn't a designated leader. Yes, we have an ASP in place led by people who have not been trained or do not have special expertise in antibiotic stewardship. Or yes, we have an ASP in place led by people with special expertise and training in antibiotic stewardship. If you could please select your choice from the polling questions on the left, or on the right, I apologize. Jennifer will be posting those results for us so we can have a sense of who we have on the line today and where you all are with regards to your antibiotic stewardship program. Great. So it looks like quite a few folks who are on the line have an antibiotic stewardship program in place that is led by folks who have specific training. And then we kind of go on down the line there all the way to a number of participants that don't have any type of antibiotic stewardship program in place. So we run the gamut, which is great. We're now ready to hand things over to today's speaker. Dr. Tamar Barlam is an associate professor of medicine at Boston University School of Medicine, attending physician in the Section of Infectious Diseases, the program director for the Infectious Disease Training Program, and the director of antimicrobial stewardship for the Boston Medical Center. She has close to 30 years' experience directing antimicrobial stewardship programs. Her research is focused on understanding factors that influence antimicrobial prescribing and the implementation and impact of stewardship interventions. Dr. Barlam, you can now begin.
Well, thank you, and thanks for the invitation to speak. So, no disclosures. Today I want to talk a little bit about what an anti-stewardship program does and its benefits. Some of you obviously will have more knowledge of that than others. I'm going to spend the bulk of the time discussing the guidelines that I co-chaired with Dr. Cosgrove that came out a few months ago that really focuses on implementation of the stewardship program. And then at the end, we can discuss some of the interventions that you think might be implemented or improved at your facility. So I think we all know antibiotics are life-saving agents, but their use is not without risks. And the biggest risk is that it promotes bacterial resistance. This is something that occurs not just for the population at large, but also at the level of the individual patient. In addition, there are adverse reactions to antibiotics. You can get rash, you can get kidney toxicity, you can get other more severe allergic reactions, but the concern of C. difficile infection is a great one because that infection is increasing in frequency and severity throughout the country. The importance of stewardship also is that very few antibiotics are being developed. Large pharmaceutical companies don't tend to develop antibiotics, so we have a bit of an innovation gap here. So what is antibiotic stewardship? Coordinated interventions to improve and measure the appropriate use of antibiotics and by promoting the selection of the optimal antibiotic drug regimen, dose, duration of therapy, and route of administration, or ensuring that every patient gets an antibiotic only when one is needed, and if needed, the antibiotic is the right agent at the right dose for the right duration. The goals of antibiotic stewardship programs are primarily to optimize patient safety and reduce resistance. These programs tend to also decrease or control costs, which is an added benefit that is of interest, particularly to the administration. Now, antibiotic stewardship is kind of hot right now, a hot topic, and several important things have happened in the past year. First, there's been a national recognition of the need for stewardship. The White House announced a national effort to combat antibiotic resistance in bacteria. There were 3 key items released on the day in September that this came out. There was an executive order from the President, a report from the President's Council of Advisors on Science and Technology, and a national strategy for combating antibiotic-resistant bacteria. And of interest to us today is that although there was other monies for surveillance and research, stewardship was prominent in all 3 documents because it works. This is going to also have implications for regulatory agencies. One of the recommendations, which is already in process, is that the Centers for Medicare and Medicaid have a new standard that will require hospitals and other health facilities like long-term care facilities to have a stewardship program or policies and procedures for and to demonstrate evidence of an active and hospital-wide antibiotic stewardship program. As a condition of participation. They've released an initial document. It's in the comment period, and the goal is to have this ready and implemented by 2017. The Joint Commission is also starting to look at stewardship, and they have a new standard requiring hospitals to have an antibiotic stewardship program to educate, monitor, track, and measure antibiotic use. So it's definitely a field, if you will, that has come into its own in the last few years, unfortunately because of the increasing public health crisis with antibiotic resistance. Now, what does stewardship do? First, it optimizes patient safety. This is one example of a study 10 years ago where with the stewardship program in red, the appropriate antibiotics, antibiotic cure, antibiotic failure all favored strongly the antibiotic stewardship program, whereas the usual practice had significantly less appropriate use and a lower rate of cure for their patients and a higher rate of failure. Stewardship also reduces some of the other adverse effects, such as reducing Clostridium difficile infections. So stewardship program was instituted, and on the bottom here, this is the C. diff, and it was significantly decreased with the stewardship program, and that's a pretty widespread observation. It does reduce antibiotic resistance, although that's often a little bit harder to prove, but in individual studies, you can see the impact. So this is a study which compared 3 versus 10 days of antibiotic therapy, and the patients who got the 3 days of therapy had 15% resistance if they had a superinfection or another infection, whereas the people on standard therapy had 35% chance of bacterial resistance. And finally, it does decrease cost. This is a number of studies, and there are many, many more, that shows the cost savings that an antibiotic stewardship program can provide for the hospital or facility where it's instituted. Ideally, a stewardship program should have a physician and pharmacist leading the program. The physician is particularly critical in interacting with the medical staff, perhaps settling disagreements of what the right answer is in terms of treatment, and also setting program goals. Ideally, they should be an infectious disease physician, but at the very least, they should be interested in antibiotic use and patient safety. And there's a few training programs that can be done online to gain that expertise. And, of course, you have to have some people skills, or you're not going to be very successful. The pharmacist is a great bridge to pharmacy and other pharmacists who are obviously right at this, an integral part of antibiotic prescribing. They can study the interventions, put them in place, monitor whether they're being done appropriately, and with the physician and others on the stewardship committee that you might put together, or team, determine program goals. The qualifications are similar. They should have some ID training or at least an interest in antibiotic use and patient safety. And also they need to feel comfortable advising physicians and other providers about their antibiotic recommendations. Now, the former guideline, which was in 2007, so almost 10 years ago now, was a very fine guideline. It spent some time, a significant portion of the guideline, talking about the structure, some of the things I just discussed about the team. But there are other documents now that do that very well, including the CDC core elements of the stewardship program. It also wasn't focused enough on implementation. So we decided to start from scratch. We wanted to focus on specific strategies for implementation, and also expand the scope of it to talk about pharmacologic optimization, the role of micro, and other metrics that you can use to assess the program. We attempted to acknowledge other stakeholders besides physicians or ID physicians or pharmacists at large tertiary care centers, where a lot of the advice in the past seems to have been directed. So we really wanted to present options for community hospitals or smaller facilities. And we referenced some special populations and settings. Just to mention briefly, the way that guidelines are now, the evidence is now evaluated is quite different than it also was 10 years ago. In the past, if you had a randomized controlled trial, it was almost automatically a high-level recommendation, and an observational study was a lower level. But the so-called grade system not only looks at the quality of evidence, but they look at the balance between the benefits, the harms and burdens, and perhaps the patient's values and preferences. So that impacts what the recommendation is going to be and how you institute it. So we're going on to the guideline now. We organized the guideline into 5 sections. Some basic intervention strategies that focus more on the pharmacologic optimization, strategies that involve the microbiology department, different ways to measure antibiotic use, to judge your program, and to benchmark against other programs. And as I mentioned, we touched on some special populations. So we'll start with the first section, interventions. We In the grade system, what you do is you develop a question. You say, who is the population? What is the intervention we're thinking about? What are we comparing it with? And what are the outcomes? So the comparison is basically not, in this guideline, is not doing the intervention. So the first one is pre-authorization and or prospective audit and feedback, didactic education, clinical practice guidelines, and that's facility-specific clinical practice guidelines, not a national guideline like this one is. Syndrome-specific stewardship, interventions to reduce rates of C. difficile, prescriber-led antibiotic review. So in other words, the prescriber taking the responsibility to do what a stewardship person might do. Review the medicines, de-escalate if necessary, make sure they're on the right antibiotics. Computerized clinical decision support, and antibiotic cycling and mixing. And I won't discuss all of them, but I'll discuss the first few. Now, pre-authorization and prospective audit and feedback is really the cornerstone or the foundation of antibiotic stewardship. To some extent, this is often what you're doing. You can do one strategy, you can do both strategies, or the key is that you want to do a strategy that you can keep up, that you can be consistent with. Many hospitals don't do pre-authorization because that requires someone who's available to answer pages or phone calls when a doctor wants to use a medication that is restricted at that hospital. If you don't have somebody with that expertise that's on site or available on some kind of a regular basis, it's hard to do pre-authorization. Similarly, prospective audit and feedback, it's more flexible in terms of the schedule because you could just decide I'm only going to look at certain things on Mondays and Thursdays or what have you, whatever your institution is able to do. But if you're a hospital that doesn't have a very good, for example, computer system that can give you the patients that you need to look at, it can be frustrating. The prior guidelines clearly preferred prospective audit and feedback over pre-authorization, and we felt that was a little unfair. The literature doesn't really support that pre-authorization is less good. In a meta-analysis of this study called it restrictive rather than pre-authorization, but restrictive versus persuasive interventions. The restricted work better and work faster on prescribing. So if you really want to handle a problem and get a result quickly, this is the best way to do it. It reduced C. diff and antibiotic resistance, but after a year they do become pretty equivalent in the study. There was another study by NATA who, their hospital, they decided that they were going to stop doing pre-authorization, but rather let doctors use what they wanted. And then at day 2 to 3, they would do prospective audit and feedback and encourage the physicians to either keep that antibiotic, de-escalate, escalate, etc. And they found that wasn't very successful. They had longer durations of therapy and longer hospital stay. So based on studies like this, we felt that they certainly were at the least equivalent. So the deciding factor should be whether or not you can do it consistently and have the physicians understand that this is something you're doing. In terms of didactic education, we really just wanted to make the point that lectures alone are not stewardship. So if you have somebody who gives a talk to the medical staff or gives a talk to the pharmacy staff, even if they do it several times a year, that really does not improve prescribing. It doesn't change practice unless it's part of a more comprehensive program, in which case it can be a very effective part of that program to kind of set the stage for your intervention, but then have other ways of proceeding with the intervention. On the other hand, clinical guidelines that are for the facility. So, as an example, you might take the guideline on treatment of Staph aureus infection, and you might individualize it for the drugs that you have on formulary, for what your physicians think is the best algorithm, et cetera. So they can help direct prescribers to the preferred agents, and they also are helpful because they're a basis on which to have a discussion. If you want to encourage them to change an antibiotic, or you're trying to explain why you're not approving an antibiotic, authorizing it, having this foundation that they can look at with you is very helpful. And the hospitals base it as well on your local formulary, but also your local resistance. So what might be good at one site on the West Coast may be very wrong for a hospital in Chicago, just because of their resistance pattern. Now, syndrome-specific antibiotic stewardship is it's maybe not a new concept in the sense that people have been doing it to an extent, but they haven't necessarily called it that. So what it is really that it's very hard to be all things to all people. So if you have a hospital, if you look at every antibiotic order or every infectious syndrome, it's very overwhelming because a third to even higher of patients who are admitted to most hospitals are on antibiotics. So it's a lot of work, and a lot of the work is not necessarily productive. So what this is encouraging is take a more focused approach. Perhaps in the fall, you look at pneumonia. You have a guideline for pneumonia. You want to see if people are doing the right thing, and you give them feedback, and you measure your data. Maybe you need to continue it, or maybe you want to try looking at urinary tract infections next, or skin and soft tissue infections. It reinforces your local clinical guidelines, your algorithms, and it improves sustainability because it's a targeted message. And that's one problem with stewardship, is that we have so many different messages based on the patient, the antibiotic, et cetera. So this allows you to really have a focused message that you can really drive home with your staff. And possible targets, as I mentioned, are community-acquired pneumonia, but also skin and soft tissue infection, nosocomial or ventilator-associated pneumonia, asymptomatic bacteriuria, which should not get an antibiotic, and positive sterile site cultures, primarily blood cultures, to make sure they're treating those correctly. In terms of Clostridium difficile, it's so important. The CDC ranks it as one of the top 3 most urgent threats related to antibiotic resistance and antibiotic use. So the overuse of antibiotics definitely leads to higher rates of C. difficile. And as I mentioned, it's causing increasing morbidity and mortality, especially in our older patients. So we felt that really it wasn't that there needed to be a separate C. difficile intervention, particularly if you were having a problem, that there wasn't a C. difficile strategy. It was basically the same thing. It could be syndrome specific. You look at diarrhea. It could be prospective audit and feedback. You look to see if people are giving Clinda when they didn't need to. Or it could be pre-authorization. You just restrict a drug like clindamycin or a 4th or 3rd generation cephalosporin that have high associations with C. difficile. So it really spans many of the other interventions, but we did think it was very important. Okay, so moving on to optimization. This is really talking about having pharmacists basically monitor and adjust doses. It uses their understanding of PK/PD to really optimize the therapy for patients. They also can optimize the route of administration, so if someone can be on PO meds, that they should be. They can address whether someone is put on an antibiotic that the record says the patient is allergic to. And also, duration of therapy is an important part of optimization. Now, many of these interventions don't have to be, quote-unquote, the stewardship team that does it. But the routine pharmacy activities can do many of these things, such as gentamicin or bank monitoring, the IV-to-PO exchange, when you're going from an IV form of the same drug to the oral. When you're going from an IV drug that needs a little bit more decision-making, that's where the stewardship program can help. Alternate dosing based on these principles, such as once daily dosing for aminoglycosides, extended infusion for beta-lactam, and also allergy testing. People have allergies listed that they don't really have, and a lot of patients get drugs that are second or third line because they think that they have an allergy to penicillin or cefazolin. So collaborating with allergists can be very helpful to enhance the use of first-line agents. Duration of therapy, I think, is a very important stewardship activity. It actually is one of the aspects of this guideline that has the best data. There are many different trials. Many are randomized controlled trials. Others are meta-analyses. And they've really shown in many instances that shorter can be as good or better. They've shown it for ventilator pneumonia, community pneumonia, skin and soft tissue infections, intra-abdominal abscesses, pyelonephritis. And you can incorporate into your local guidelines and algorithms the duration of therapy you suggest, or you can do prospective audit and tell patients, doctors that, the patient has already had X number of days. They really don't need to continue to be on the antibiotic. And it also is very effective because when you look at the reasons that drugs are inappropriate, this study found that 30% of antibiotic therapy is unnecessary. And a good chunk of that is because they got the antibiotics for longer than needed. So it really is a very productive intervention. Microbiology, there are many things you can do working with the department or off-site micro labs. You have to, obviously there it's more difficult. You have to establish a relationship. You can use your antibiograms to divide into different populations, such as a general ward versus an ICU population, an adult versus a pediatric population. If you have enough data to do it, there are susceptibility reporting strategies. So you run so the lab knows, but you don't actually report broad spectrum agents when more narrow spectrum agents are active. That's one strategy. There are different molecular tests for respiratory pathogens such as flu or, a comprehensive panel of many viruses. And by having these readily available, the doctor can say, okay, this is a viral syndrome. I don't need to give an antibiotic. You also have a blossoming field of rapid diagnostics, primarily for blood cultures. And procalcitonin is another thing, a biomarker that's coming into increasing use, as well as fungal markers. So I think I discussed the first two a bit. And I want to talk now about a bit more about the rapid diagnostics and procalcitonin as well. So there are several different ways to do rapid testing. The PNA fish is relatively limited. The PCR is available for many organisms, and some of the assays also give you resistance information. This last one, MALDI-TOF, it gives quick identification of bacteria, but they don't really tell you. They don't have any way to tell you what the susceptibility is. So each of these can be very beneficial, but that's only if the physician actually acts on it in a more rapid way than they would have acted on conventional culture data. So this is really where the stewardship program can help. They can work with microbiology first to prioritize what tests are going to be most useful, and they can maximize benefit. If the stewardship program gets involved in knowing these results and talking with the clinicians in a very timely way, that's really where the studies have shown that there are good results. studies have similarly shown that if you don't have that, you don't see the same results. So if you just put a rapid test in place and you don't have this system where the stewardship program can be involved to make sure that the physicians respond to the information in a timely way, you really are spending money on a often expensive technology that you're not getting any benefit from. Procalcitonin is an interesting biomarker that's released specifically in response to bacteria. There seems to be a correlation between the level and the extent or severity of infection. It's also very sensitive in terms of it goes up quickly, and then when the infection is controlled, it goes down quickly. It's mostly been studied in respiratory tract infections to both reduce initiation of antibiotics as well as shorten the duration, and patients have similar outcomes. In sepsis is the other area where if you have a septic patient, I don't know anyone who would refrain from giving antibiotics, but it helps reduce the duration of antibiotics when the procalcitonin demonstrates that the levels have significantly decreased or gone down to normal. Now moving on to measurements. So I'm going through maybe a little quickly, but I wanted to have time for questions and interaction. So the two most common ways to measure antibiotic use, and you really have to measure antibiotic use. If you're going to have a stewardship program, you have to have some way to know, is it working and how is it working? If you do an intervention, you want to know if it was better after the intervention than before. The two major methods are days of therapy versus what's called defined daily dosing. You can also, and you should do several of these as well. You can measure expenditures, and you could also measure the results of your targeted or syndrome-specific interventions. Overall, the days of therapy is preferable. It isn't impacted by dose adjustments, so it doesn't matter if the patient's vancomycin dose has to be increased. The day of therapy just is what is counted. Whereas in the defined daily dosing, the way that they calculated it, it does have an impact. It's useful in both adults and pediatrics, so the other method is standardized that doesn't take into account the different dosing in pediatrics. And also the CDC is developing an NHSN, antibiotic usage reporting that they're hoping will become used in a widespread manner, and they use days of therapy. On the other hand, defined daily dosing doesn't need patient-level data, and not every institution has patient-level data, and days of therapy requires it. So it may be an option for many facilities, and it's still a very useful way to measure overall use by unit, etc. The costs are ideally measured on prescriptions or actual administrations rather than purchasing data. And that's because you often will stockpile if you are getting a good deal, or if you know that a shortage is coming, you might buy a lot of cefepime, for example. We have a shortage of cefepime right now. That will give an accurate sense of how much drug you're using, whereas if you look at actual administration, it's much more accurate. And then you normalize by your patient sentence. Now, it's important in terms of you continuing to convince administration or whoever is supporting the stewardship program that it is a cost-effective program. But if you just look at cost savings, that isn't necessarily the best, because you first get the low-hanging fruit, and then it tends to plateau. So what you really have to do is measure what the cost would have been if you did not have a stewardship intervention program, and compare that to what it actually is. For the syndrome-specific, there are many things you could use. You can look at how many days of therapy you avoided based on historically what they were using and what they used after the intervention. Similarly, the duration of therapy, compliance with your guideline, proportion of patients who had their antibiotics revised based on microbiology data, proportion of patients converted to oral therapy, length of stay, mortality, unplanned readmission, C. diff, or clinical failure. So there are many different things that you could use to measure the success of an individual intervention. And we mentioned special populations. Unfortunately, there just isn't that much research in these populations. The stewardship for cancer patients, there is a clinical guideline for fever and neutropenia and antifungal pathways, but it's hard to know how to safely de-escalate in persistently neutropenic patients. And there is really not a great study about that. But there are certain instances where it seems like it's safe, particularly with the gram-positive coverage. Stewardship can be done in neonatal ICUs. Not only can it be done in long-term facilities, it's going to be required to be done in long-term care facilities. So there, a lot of the emphasis might be on not treating asymptomatic bacteria or not treating a viral bronchitis with an antibiotic. And then an issue of stewardship for terminally ill patients with pneumonia. Patients in their last weeks or months of life use a large proportion of the antibiotics that are prescribed. And they become reservoirs as well of resistant bacteria, and it doesn't really improve their outcomes. So it's a discussion that should be had with the patient as well as the patient's family or healthcare proxy, how aggressive they want the team to be with antibiotic treatments. So we sought to create a guideline, as I mentioned, that was really more practical, that was really talking about what you can do, how you can do it, what's the data that it's a good strategy. Unfortunately, the stewardship literature is not that strong, so a lot of the recommendations by the rules came out as weak recommendations. So we did supplement our recommendations with comments, which isn't done in other guidelines. And the comments is meant to give you a little bit more information about where it can be used successfully, what kind of setting, etc., just to give you a little bit more of what, if you will, the expert panel's view was about a particular intervention. We also then create a tiered list of interventions. A lot of entities have tried to create, okay, these are the first interventions you should do, then at the level 2, you should do these, etc. But no one really agrees what should be on each tier, and different facilities can do different things more easily than others. So you might say an antibiogram is on, I don't know, the second tier, but if you're at a place where that is just, always done and not difficult to do, then it doesn't make sense that that should be on the second tier. So we didn't really do that. I just wanted to finish up by acknowledging my co-chair, Sarah Cosgrove, and the members of the guideline panel. And now I think we can open it up to questions.
Great. Thank you so much, Dr. Barlam. We really appreciate you taking time to share all of your expertise with us on this important topic. As Dr. Barlam noted in a review of the objectives, we're hoping that everyone can walk away today having identified at least one antibiotic stewardship program intervention that could be implemented or enhanced at your facility. And we'd like to do a quick poll to find out, of the ASP strategies discussed today, which do you plan to focus on? Education and guidelines, diagnostics, pre-authorization and prospective review, medication optimization, or one of the other areas, and if so, please share your answer in the chat box. So we'll give folks just a moment to answer the polling question that's on the right-hand side of your screen. Great. And Jennifer will be posting those for us. But we'll now be opening things up for questions. And we can start with one that came in through the chat. But before doing so, Daryl, can you please provide instructions for how to ask questions over the phone?
Thank you. We will now begin a question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone.
Great. And we have the results from the poll. A number of folks chose not to answer the question, but of those that did, 23% identified education and guidelines, 22% identified medication optimization, and then next in line were pre-authorization and looks like diagnostics, and then a couple people chose other, so we're hoping that they'll chat in their answers as to what they're looking to focus on. One question that came in while you were speaking, Dr. Barlam, one that came in through the chat box is from Toria Spencer. She asks, are there any sample tools, templates, or documents for standardizing care for PNVAP?
What is that abbreviation?
I'm not positive. Pneumonia, I'm thinking possibly, but I'm not sure what VAP stands for.
Oh, VAP? There are a variety of tools and templates. If I'm understanding the question correctly, you're talking about guidelines for pneumonia. Is that what?
Yeah, the question was, are there any sample tools, templates, or documents for standardizing care? And Toria, maybe if you want to dial in to ask your question over the phone?
Yeah, there are. One site that's very useful is on the SHA, the Society of Healthcare Epidemiology of America. If you search for stewardship, they have a page that has a lot of different tools from different folks, kind of like the sepsis site has, where they give you different tools there. So that's one good place to go. There have been toolkits that have been developed. And then, of course, there are lots and lots of guidelines that the Infectious Disease Society has developed, and that's open to anybody on their website. It's not member restricted. And you could certainly use those guidelines to create some pointers for your facility-specific guidelines. But the best place, I think, to start would be the stewardship page on the SHA website.
Great, thank you. Daryl, do we have any questions on the line?
No audio questions at this point. If you have a question, you can press star then 1 on your touch-tone phone. And we have no audio questions at this time.
Thank you. All right, well, if there are no further questions, we'll wrap things up a bit early today. As a reminder, please...
I just wanted to say one thing. I see a low number looking towards pre-authorization and prospective review, and I don't know if that's because they're already doing it or because it seems too burdensome. And I just wanted to, again, say is that you can make it as burdensome as you can tolerate. So if you can only do prospective review 1 day a week, then that's still an effective intervention. If you can authorize Monday through Friday certain drugs, that's still probably a worthwhile intervention. So I just wanted to mention that.
Great, thank you. Yeah, do you have any other comments or thoughts following the polling results?
No, I think that, again, just to reemphasize that the education and guidelines really do work best when it's part of a multifaceted program. So that's where you might want to limit the amount of guidelines you do so that you could focus just on one diagnosis at a time.
Great, thank you. Well, if there are no further questions at this time, we will wrap things up. As a reminder, please take a moment to provide us feedback on the evaluation that will automatically appear when you close out of the webinar. And upon completion of the evaluation, you will have access to a certificate of attendance for today's event. Thank you, Dr. Barlam, for joining us today. We appreciate you sharing your expertise with us, and thank you everyone else for joining.
And thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.